Okay, today,
Good. I'll just make the introduction.
Good afternoon, all. Today, the topic is to discuss OIs, cutaneous OIs, which are commonly seen in HIV patients. And so I'll be talking on skin and mucous membranes, how they get affected in patients who are PLHIVs. And I'm Dr. Bela Shah. I'm professor and head Department of Dermatology, BJ Medical College, Civil Hospital, Ahmedabad. The first and foremost, we'll have to have the level of understanding of the participants. Why the slides not moving?
Right, ma'am. They're moving now. Yes, ma'am. The slides are moving.
There are no questions now?
No, ma'am. No.
Okay. So this is the schematic slide which says how this topic is going to be, delivered to all the participants. So briefly, I will introduce to the topic and what are the skin manifestations of common bacterial infection, that is staph and streptococci. Then we'll take you through fungal infections, viral infections, acid infections, what are the common inflammatory conditions seen in these patients, as well as the miscellaneous conditions and few of the cutaneous malignancies, which we have seen in our subset of patients, which pictures from other centers as well as from my center. So it is very, very important to remember that more than 90% of the patients will develop skin or mucous membrane lesions in the journey of their disease, that's HIV, right from the seroconversion illness, wherein the patient can manifest with maculopapular rash, and over the period of time, they have a plethora of skin manifestations. And I'm going to take you through those common manifestations. And we have to remember that not only in adults, but the skin manifestations are also frequently seen in children, and up to 52% of the children who are CLHIV can have variety of skin manifestations. And it is very, very important to identify these conditions because few of them can also predict the level of CD4 counts in given subject, and also it can predict the course of the disease. And finally, we need to remember that persisting, recurring, chronic, little refractory lesions, severe lesions, and atypical lesions can be seen in patients who are seropositive. So this is the chart which takes us through the spectrum of skin manifestations which are seen in patients who are PLHIV. So if you can focus on the first block, wherein we can see when the patients develop seroconversion, patients can develop maculopapular rash and the CD4 count goes down even below 500. And when the CD4 count is even above 500, patients can have common infections like dermatophytosis, and patients can also present with inflammatory skin diseases like seborrheic dermatitis, psoriasis, etc. And patients can also have lot of infections in the form of impetigo, folliculitis, furuncle, and so on. The skin infections, especially the bacterial infections, are seen while the patient's CD4 ranges between 200 to 500. And of course, they are likely to develop even viral infections like human papillomavirus infection causing warts, molluscum contagiosum. It is again a DNA poxvirus, and it is very commonly seen on face of adults, and there are multiple lesions. And I have seen number of children with multiple mollusci developing on their forearms, on their trunk. Then we have to remember that every patient who walks in with wart or molluscum is not PLHIV. One more infection, which is very common, that is Pityriasis versicolor. It is also seen commonly in competent host, but it can also be seen in PLHIV patients when the CD4 count is in the range of 200 to 500. And with advanced immune suppression, that is when the CD4 below 200, the patients are likely to develop number of OIs, cutaneous OIs like herpes simplex, herpes progenitalis, and the herpes labialis, that is, which occurs around the lips and nasal cavity, wherein the patients will have ulcer which can remain there for more than 1 month. And when it remains for more than 1 month, it becomes AIDS defining illness in such cases. So it is very, very important to diagnose this simple looking infection, that is herpes labialis. Patients can also develop oral candidiasis, esophageal candidiasis, leukoplakia, and dryness of the skin, which may even manifest as acquired ichthyosis. And rarely, few patients can develop Kaposi sarcoma, and few patients can present with Norwegian scabies. So now coming to the most common infections, they are bacterial infections, which are seen in such patients. Also, we do see viral infections, at times fungal infections, and many times we will come across even parasitic infections. So mainly, broadly, the dermatosis which are seen in this patients are infective conditions, inflammatory diseases, cutaneous malignancies, and miscellaneous skin conditions. So what are the common bacterial infections? What we see in these patients are folliculitis, furuncle, abscess, eczema, and impetigo. Even cutaneous tuberculosis is not uncommon. Many times we have seen patients who developed cutaneous diseases due to atypical mycobacteria. The typical skin condition what we see is bacillary angiomatosis, which is seen in background of PLHIVs. And syphilis is STI, which manifests on skin. Primary syphilis will manifest as genital ulcer, whereas secondary syphilis will have a lot of cutaneous, and many manifestations will be seen on the mucosa as well. The oral cavity can have mucus patch, and many more things can be seen. Condyloma lata and various types of rashes are seen in patients who develops secondary syphilis. When it comes to fungal infections, most commonly we see oral candidiasis, esophageal candidiasis. Again, esophageal candidiasis, if the patient has, then it becomes resist, and we can come across extensive dermatophytosis. We have seen patients, adult patients, even who have involvement of their hair and scalp, which is not common in adult patients, but it is seen in pediatric patients. Of course, the deep fungal infections are also there, which can occur in these PLHIV patients, and they are cryptococcosis, paniciliosis, histoplasmosis, and many more. The viral infections. The most common viral infection what we see in our patient is herpes zoster, herpes simplex, then molluscum contagiosum, then verruca vulgaris, verruca plana. And you need to remember that Condyloma acuminata is a human papillomavirus infection, and it is also known as anogenital warts or genital warts. So we need to remember why the word acuminata, because it is pointed lesion. What you see in secondary syphilis is lata, which are flat lesions. But when it is HPV infection, it is pointed lesion with verrucous surface, and it is known as Condyloma acuminata. It is again caused by certain subtypes of HPV. And few of them are even carcinogenic, or also known as oncogenic varieties of HPV virus. Coming to the arthropod infection, scabies is quite common in our community. Even patients without HIV, see bulk of patients who with scabies. Rarely I have come across few patients, especially from endemic regions. We have seen patients with leishmaniasis, Simplex, folliculitis. Now coming to the list of inflammatory dermatosis, what is common in these patients is dryness of the skin, which is described as xerosis. Patients can develop secondary due to HIV infection. Psoriasis vulgaris is otherwise common and it can occur in patients who are PLHIV. Seborrheic dermatitis, wherein the patients will have a lot of swelling on the face, in the pre-sternal area, as well as on the scalp. Few patients can develop reactive arthritis. Previously, it was known as Reters syndrome. And the typical condition which is seen in context of HIV is eosinophilic folliculitis, which involves head and neck, and it is not due to any of the bacterial agents. Of course, patients can also develop atopic dermatitis in context of HIV positive status. The cutaneous malignancies which have been reported to occur in this subset of patients are Kaposis sarcoma and non-Hodgkin's lymphoma. And of course, if you enlist the miscellaneous condition, there are many more than what is seen on your screen, like acute seroconversion illness will manifest maculopapular rash, fever, malaise, lymphadenopathy, and even oral ulcers. Now, of course, drug reactions have gone down with introduction of change in the regimes of ART. When nevirapine was used as first-line drug, we see a lot of HJS and 10. That incidence has gone down because of the change in the first-line drugs. And of course, pruritic papular eruptions we have seen in number of cases for 15 years. That's also going down. So now coming to the skin manifestations, how does the bacterial and infection will manifest in these patients? Let us go through this. The picture will be more than what I will try to explain to you. So here you can see a patient who has developed multiple follicular pustules on his pubic region, which are almost resolving now, but initially they will be having redness, they will be filled with pus, patient can develop little pain, and there can be even regional lymphadenopathy if the extent of involvement is much more. And the bacteria which causes this is Staph aureus. That is the most common bacteria which gives rise to this bacterial infection on the surface of skin. As you can see the second picture, that is deep necrotic ulcer, which is covered with crust. When you remove the crust, it will show underlying ulcer, which is known as ecthyma. That is again caused by Staph aureus. Mostly single lesion will be seen and patient will have little delayed healing and it will result into scar at times. The other picture shows a child who developed honey-colored crust just below his lower lip. This is very characteristic of impetigo contagiosa, and again it is caused by Staph aureus very commonly. Rarely it can also occur because of the streptococci. So these are the various manifestations, bacterial infections, and we can have even development of abscess or boil. The patients have impetigo, which is impetigo contagiosa, or bullous impetigo, which is very common in pediatric age group, especially patients who are toddlers. So it is very important to identify these diseases, and they're simple to identify. Not a big, we can easily diagnose these conditions. Only thing we have to keep in mind is that not that we can label every patient who walks in with lymphatic or bullous simpatico. We just think in terms of only HIV. It is not so. These conditions, these are very common conditions, bacterial infections, and they do occur with a lot of high prevalence in our community. But when you know, when you are treating a patient who is already having this status known to us, we should be able to diagnose with much more ease. And again, this bacterial infections remain quite common even in pediatric age group as well as in adults. So how do we manage these patients? So it is better to guide them about the general hygienic measures, and topical antibacterial agents are enough to treat impetigo. We will not have to start oral antibiotic in most of the cases, but then we can start these patients. If there is a need to start oral antibiotics, then oral cephalosporins or even erythromycin or aminopenicillins are better drugs. Initiate, still need to rupture this bulla. They will rupture themselves. The patient gently, clean water. Patients are allowed to take bath. There is no point in asking them not to take bath. They have to take bath. If the patient develops abscess, naturally abscess is quite deeper. It is deep-seated inflammation and infection of multiple hair follicles. And when they merge together, there will be abscess formation. Initially, it will be hard swelling. Later on, it will become fluctuant. At times, it will just exude the pus by itself. In few patients, we'll have to subject these patients for IND when it does not rupture by itself. So surgical drainage, we don't ask patients to undergo in every patient. We have to see clinically whether the patient has developed the fluctuation, and if the abscess is about to give in, then we can allow it to flow the pus by itself. If it remains indurated and inflamed for a long period of time, say for example for 4 or 5 days, and it is not giving its way, then we should ask surgical drainage of this abscess. Rarely the patients can get the involvement of their muscles. We can occur in patients who has got advanced immune suppression, and there will be formation of deep-seated abscess, which will occur in muscles, which is described as pyomyositis. So we have to be aware when the patient has a lot of pain, deep-seated abscess, large swelling, inflammatory swelling, then we should start these patients on cephalosporins and aminopenicillins, and even fluoxetine is the drug of choice, especially for staph. The patients with severe sepsis, we can admit them and they can be given even intravenous antibiotics as per the antibiotic policy of the hospital. Furuncle or folliculitis, we may not require them to be drained. They are amenable to topical treatment as well as oral antibiotics, and typically the furuncles and folliculitis can be seen around hair follicles. So in the groin, in the axillae, on the trunk, on the face, even on the lower limbs, hairy limbs, you can have folliculitis and furuncles. Carbuncle typically we see in patient who is diabetic, but again we can see carbuncle as a presentation in patient who is PLHIV, and we know that carbuncle will have multiple openings, sieve-like openings, and that will exude all the pus because the inflammation is quite down in the subcutaneous fat. So this is a very typical situation or the clinical condition labeled as Bacillary Angiomatosis, and it is again caused by bacteria. The name of the bacteria is Bartonella, and the subspecies of Bartonella which causes Bacillary Angiomatosis are Bartonella hensselmi and Bartonella quintan. How does it initiate? Typically, there will be red macules initially that will grow in size and become papule, and it can become a large nodule or even they can become pedunculated. They have vascular appearance. That means they have red appearance, and at times they bleed easily and they are friable. Patients can develop fever, night sweats, weight loss, anemia also. And patients can develop even visceral lesions. So it is very, very important to diagnose this condition early in the course of the disease. Even liver and spleen can get involved, and that can occur even without involvement of skin, and that is labeled as visceral form of bacillary angiomatosis. We can confirm our diagnosis by doing biopsy and staining the slide with silver impregnation. Of course, electron microscopy, we do not have reached to this specific microscopy. Hence, we'll restrict ourselves to silver impregnation staining of the biopsy specimen. How do we treat this condition? The drug of choice is erythromycin. We have to give 500 milligram for 4 times in a day, or doxil 100 milligram for 3 months. Alternatively, we can use azithromycin in the dose of 500 milligram. Now coming to other very, very common bacterial infection is skin tuberculosis in context of PLHIV. And we can see the most common form of skin tuberculosis we see is TBVC, that is tuberculosis lupus acutus, lupus vulgaris, and scrofulloderma. Here, what you are seeing right now on the screen are the 2 examples of patients who have developed scrofulloderma. The tuberculous focus is either underlying lymph node, or joint, or bone. It ruptures and forms such puckered scarring surrounded violaceous color. And here you can see on the right side of the screen a female who has got multiple sinuses, and she is using a lot of pus. So these are 2 classic examples of scrofulloderma caused by M. tuberculosis. So as I mentioned, skin tuberculosis still remains common in Indian population, and in PLHIV, we have seen number of patients who have developed scrofulloderma. But what is important to remember here, that we should rule out even atypical mycobacterial infection like Mycobacterium avium intercellular, because it can also present as patient can develop chronic sinuses. The presentation can be as scrofulloderma, as we saw, which was caused by M. tuberculosis. So it is important to subject these patients for bacterial cultures and find out what is the etiology of this particular disease. Not only that, it can give rise to even chronic ulceration in the patient. So it is better to take a sample and do gram stain, culture, etc. So to confirm the etiological agent. We should remember, even rarely, Mycobacterium hemophilium can cause cutaneous abscesses, ulcerations, and even tenosynovitis or arthritis. So tuberculosis is very common in India, even otherwise, and in context of HIV, they are crimes in part, they are partners in the crime. So we should not forget about tuberculosis, and of course, we treat this patient guidelines, whether it is typical Mycobacterium infection or atypical Mycobacterium infection. So we have to go by the national guidelines. Now coming to syphilis, which is probably I'll talk much more while we discuss STIs, but since it is covered here, of course, primary syphilis, we see single ulcer, which is painless, it is indolent and associated with inguinal lymphadenopathy. Whereas secondary syphilis has got a variety of skin manifestations. And what is the current scenario? We see palmoplantar syphilis much more than the surface of the skin. And we can have variety of skin presentation, and involvement of mucosa is also not uncommon when the patient presents with central syphilis. Of course, how do we treat? Everybody knows kit, which kit do we use? for this patient. We use with benzathine penicillin 2.4 million units, and it has to be divided in the dose of 1.2 million units on every 2 months. Of course, if the patient has negative intradermal test, then and then we can give, and of course these patients require follow-up, and we have to see the RPR becomes negative, and we have to see the fall of titer also. Here you can see the example of primary syphilis, wherein you can see the ulcer which is on the middle of the shaft, and the typical palmoplantar syphilitis, which are also described at times athletic or knee. So we are done with the bacterial infections. Now we'll enter into another type of infection, that is fungal infections. Firstly, we'll talk about superficial fungal infections. So how does the patient will present? This is, I think, Candidiasis, right? So patients can have Candida intertrigo, wherein we will find the fiery red erythema, even erosions, and the periphery of this particular erythema is studded with pustules. And as I mentioned, the hallmark is the satellite pustules, which extend centrifugally from the eroded areas. Oral candidiasis is very common presentation, and we have seen number of patients while HIV was in initial stages. It is very common manifestation which is seen in PLHIV. We can see variety of candidiasis. There are 6 subtypes of oral candidiasis. The most common is thrush. And candida can also involve nails, paronychia, and multiple infections can be seen because of candida, right from the esophageal candidiasis, oral candidiasis, paronychia, onychomycosis. And how do we diagnose? We have to just take a smear and put it under 10% potassium mercaptan, and we can see the fungi which will show potato-tuber appearance. Candida is saprophyte. The pathogenic form will show tuber formation, and that is pathogenic form. Otherwise, it is commensal in oral cavity. And how do we treat? We can use fluconazole 100 milligram for 10 days. And of course, we have plethora of topical drugs to apply. So now coming to another common infection, that is dermatophytosis. And this is right now, our country is undergoing a huge epidemic of dermatophytosis right now. And patient presents with a lot of varieties of tinea infection, extensive tinea infection, even erythrodermic tinea infections. In ring, pustules, breakouts, involvement of face, even infants are involved. So we should be very skeptical in diagnosing this common infection, that is tinea of face, fasciae, corporis, manus, pedis, capitis, even of beard, and of course the nails. So we have to remember in children, tinea capitis is quite common, even otherwise. And when they have their positive, we should be paying extra attention and try to do a correct diagnosis of tinea capitis. By doing appropriate examination, we can check under Wood's lab, we can make QH smear, and we can find out the spores, whether they are lying within the hair or outside the hair. So this is very common condition. What we see in our clinical practice is Pityrosporum versicolor, Tinea versicolor, or it is Malassezia, caused by Malassezia group of fungi like Pityrosporum ovale and Pityrosporum orbiculum. What we see on the skin surface is hypopigmented macules and patches with little elevation of the border, and it is covered with very fine skin. And this fungus is also a saprophyte. It is found on the surface of body, and the host-parasite relationship gets upset. Patients will develop multiple hypopigmented lesions. At times, it can be even colorful. It can be dark in color, which is also known as chromic. The most common site wherein we see tinea versicolor is trunk. chest, even in infants we see on face, especially around the eyebrows and around the nostrils. Of course, diagnosis is clinical, but we can always do KOH, which will show spaghetti and meatball appearance, short hyphae and multiple spores. We treat these patients with 400 milligrams stepped, and the patient has to apply topical antifungal agents for at least for 4 to 6 weeks. And the hypopigmentation may remain for a long period of time, which can be addressed by asking patient to expose the skin to sunlight for 5 minutes. This is very, very important infection, deep fungal infections, which are seen in patients who are positive PLHIV patients. What we have seen in our clinical practice is patients develop cryptococcosis and histoplasmosis. Of course, paniciliosis is common in northeastern part of India because the vector is bamboo rat, and there it is quite commonly seen Manipur and Meghalaya and Assam. We have seen in our practice patients developing histoplasmosis, cryptococcosis. The sporotrichosis is endemic in India in areas, sub-Himalayan areas. It is commonly seen in Himachal Pradesh. We have seen few cases, but not in context of HIV positivity. Of course, these patients can develop other deep fungal infections like coccidiomycosis, actinomycosis, and even aspergillosis. But this requires a lot of skill and a lot of investigations to confirm the diagnosis of Aspergillus or coccidiomycosis. Mycosis is synonymous with paniciliosis, and it is the patient will present with papule which are having central umbilication. And again, we have many umbilicated lesions to differentiate. The most common is mollusc, second is cryptococcus, third is histoplasmosis, and fourth is paniciliosis or teluromycosis. And the lesions typically develop on face, can occur on extremities, and even trunk. Of course, cryptococcosis, we have seen patients develop this umbilicated on face, on the forearm, the body. Here you can see 3 different subset of patients. The first one from Manipur with a large lesion with central crust and umbilication. The second patient whom I had seen long back, who also had CNS cryptococcosis, patient was comatose, was referred from medicine ward, and we can see multiple papules. If you look closely, few of them did show umbilication. We can make smear and see, and of course biopsy is confirmatory. And the third slide shows a patient presenting with multiple papules which are asymptomatic, and this was a case of histoplasmosis. Biopsy is mandatory for confirmation. Clinically, you cannot tell that this is paniciliosis or cryptococcosis or histoplasmosis. So we must take biopsy, have the proper diagnosis, and patients can be subjected to definitive therapies. So this was all about the superficial fungal infections as well as deep fungal infections. And now I am going to talk on viral infections, which are also very, very common otherwise in the society, but they become important when they occur in patients who are seropositive. So this is something which is not very common, but we should know about it because the etiology is probably thought about. That is, it's also caused by one of the subset virus of herpes group. So we have to remember the herpes virus infection is associated with all subsets of sarcoma, whether it is endemic subtype, classic, transplant related, or even AIDS related. The skin lesions, what we see in these patients are violaceous macules and plaques. They are non-tender, asymptomatic lesions. Mostly we see these lesions on the lower lips. It can occur in oral cavity, or also it can be seen on the face. As I mentioned, in oral cavity, what we see will be purplish, flashy swellings. In the buccal cavity, even on the roof, and we should not forget that this can also involve respiratory system as well as GI tract. Of course, there can be lymphadenopathy, and if you can read few different difficult diagnosis, it can cause primary effusion lymphoma as well as Castleman's disease. So now, little easier to understand. Cutaneous Kaposis sarcoma. So, as I already mentioned, typically they have violaceous hue, can be hypopigmented in our pigmented type of skin. We are type 5 and type 4 skin. And as you saw, localized lymphadenopathy can occur. And of course, patients, if they have respiratory involvement, presentation will be similar to tuberculosis or even TCP pneumonia. When the internal viscera is involved, most of the time patient will not have any symptoms. But if it is respiratory involvement, patient will have shortness of breath. They can have bleeding from the rectum, melena, or other non-specific respiratory and GI symptoms. Of course, we have to do biopsy, cytology, and immunological markers to confirm the diagnosis of Kaposis sarcoma. Here you can see the beautiful pictures of cutaneous Kaposis sarcoma, wherein you can see the sole is studded with a lot of violaceous papules, multiple papules. At times, you may see erythematous lesions on the dorsa foot, and it can be associated with edema fit. The other slide shows involvement of lower eyelid with typical violaceous lesions. So how do we manage? It's a difficult condition with help of our colleagues rather than we managing them. Only thing is required is to confirm the diagnosis of Kaposis sarcoma, and that is very, very important to do. Of course, patients are put on ART. Every case is now put on ART when they are detected as having seropositive illness. And when the patients have visceral or disseminated cutaneous lesions, the patients are subjected to doxorubicin along with ART. So it is always with consultation with our friends and colleagues who will initiate these patients on liposomal doxorubicin. And patients should not be given steroids. That is very important to remember. These patients should never be given steroids, even if the Kaposis sarcoma has occurred as iris. Please do not start these patients on steroids. Of course, if you are able to diagnose primary effusion lymphoma due to herpes virus, again, it has to be a chemotherapy in the form of ganciclovir, intravenous ganciclovir. This is the drug of choice. And for Castleman's disease, patients again will be started on, of course, they have to come with ART, or they should be put on ART, and along with IV ganciclovir or oral ganciclovir. Of course, other choices are rituximab plus or minus prednisone. So it is very, very important to take opinion of our colleagues while we manage these patients. We should not manage by ourselves. It's better to refer to the appropriate specialist and take their help. Patients should be getting the appropriate therapy after proper evaluation. That's very important. These are very common herpes group of viruses, and we see herpes simplex, herpes labial type 1 infections and type 2 infections are quite common. And homosexual men, more than 95% of this population will have history of herpes infection, especially type 2. this virus remains in the body, and even when they do not have overt disease, the shedding of the virus continues. That's very, very important when you're an asymptomatic patient. And it occurs when the CD4 count is low. And it is a major cause of proctitis in men who are MSM. The patients can also have herpetic keratitis, encephalitis, hepatitis, and hepatic whitlow. That means paronychia. So this can be also observed in patients who are seropositive as well as who are seronegative. So we have to remember there are various phases of herpes infection. Primary, then there is latent infection, and there is recurrences. Herpes simplex has tendency to recur, whether it is type 1 or type 2. So primary infection, when the host acquires infection for the first time, and then the virus will remain latent in the host. And the reactivation of virus occurs when the host immune system gets compromised, and which is likely to occur when the patient is PLHIV. So how does oral herpes or the type 1 herpes manifest? Typically, we see the fever blisters or cold sores, which can occur with any type of fever, especially malaria and pneumococcal pneumonia. It can occur with exposure to sunlight, acute respiratory infection, upper respiratory infection, common cold. It's very common to see patients developing herpes labialis, very common. Lesions typically seen in and around oral mucosa, that is lips, and then there are papule vesicle ulcer, and they heal by themselves, and the disease gets over by 2 to 7 days in a immunocompetent host. But with advanced immune suppression, the lesions can persist beyond 1 month, and then you have to confirm the diagnosis by making Xanthem, or we can do serology as well. Again, genital herpes I'll cover while I talk more about STIs in context of HIV patients. Of course, it is also very common, and recurrences are very common. And as I mentioned, tuberculosis and HIV go hand in hand. Same way, herpes progenitalis and HIV, they also go hand in hand. And each one promotes, HIV promotes herpes, herpes promotes HIV. It is very, very important to diagnose genital herpes and treat it adequately so as to make the patient, prolong the life of patient. Otherwise, there will be faster replication of the virus and the viral load will increase the patient's body. Here we can see type 1 herpes infection, which manifests typically as oral herpes labialis. We can see multiple fluid-filled blisters. If there is a primary intake, patients can feel malaise, fever, and followed by development of this lesions. And here you can see the genital herpes. The blisters are superficial, they are stitched, and they are grouped vesicles. When they rupture, they form polycyclic erosions. So how do we diagnose? Most of the times, clinical diagnosis, because we do not have access to diagnose these cases by subjecting our patients to PCR and viral culture. We don't do this. This is clinical diagnosis. At the most, we do Xanthem and we can see the giant cell. And of course, we do serology, HSV1, IgG, IgM, and HSV2, IgG, IgM. So how do we manage this? We start this patients on acyclovir 400 milligram 3 times in a day for 5 days. And in children, we use acyclovir in the dose of 20 milligram per kilogram body weight. But we should not exceed 400 milligram in children. If you want to use valacyclovir, the dose will be 1 gram twice in a day. Again, how do we manage genital herpes? We have to give acyclovir 400 milligram 3 times in a day for 7 days. And for recurrences, we give for 5 days. Of course, we use valacyclovir 1 gram orally twice in a day for 7 days. And for recurrences, again, it is for 5 days. Do we need to give intravenous acyclovir? This will be very few cases. And if you suspect that the patient is having severe mucocutaneous or disseminated herpes infection, then we should start these patients on intravenous acyclovir in the dose of 5 milligram per kilogram body weight 8 hourly. And in children below 12 years of age, we can start them on 10 milligram per kilogram body weight. After the lesions begin to regress, we can shift these patients to oral dose and we can continue for longer period of time till all the lesions heal. So this is the dose of acyclovir in neonates and children. And in neonates, we have to see what is the type of involvement, whether it is skin, eyes, oral, or it is only CNS disease, or it is severe gingivostomatitis, or mild gingivostomatitis. As per the clinical manifestation, the dose of acyclovir will vary. Today, I have not seen acyclovir resistance. If you suspect resistance, then the drug to go to is foscarnet. That is the drug used. Charge. Iska charge is foscarnet. So we do not have foscarnet with us. So all of the patients we managed with acyclovir, and till today we have not seen any. And you continue the drug for little more days. It is not a of concern for us at the moment. But of course, if you read the journals and articles, resistant herpes is widely reported across the globe. So now coming to herpes zoster, again it is caused by a virus, herpes virus type 3, and children develop varicella, that is chickenpox. The virus remains
Ma'am has been disconnected for some reason. She'll join us shortly.
Chemotherapy, CHOP, that is cyclophosphamide, hydroxy, daunorubicin, vincristine, and prednisolone with ART. We can see a patient who has developed multiple swellings in the axillae, in the abdomen. This is the classic case of non-Hodgkin's lymphoma. Of course, we'll have to subject these patients for the appropriate referrals, get the confirmation, and then these patients can be initiated the CHOP regime. So if you look at the male and female, it is much more males who get this non-Hodgkin's lymphoma, and it is 17 times higher in men who are HIV positive than negative men. And in women, it is 16% higher than the normal population. Now coming to the last part, that is miscellaneous conditions. Here you can see patient has developed maculopapular rash. Here the patient has got multiple papules on the face and the vesicles on the body. The drug reactions are not uncommon in PLHIV patients, and they occur usually in second week, and patients can present with rash, FD, urticaria, and so many other things. Because drug reactions are many, they occur in variety of forms. As I mentioned previously, as just an even toxic epidermal necrolysis and even DRESS, which is also known as DHS. So there are a number of drug reactions which we have to keep in mind. These patients can develop, including even erythroderma. These are the two photographs which shows patients who have developed pruritic papular eruptions on live. So what is pruritic papular eruption? The prevalence of this disease in HIV patients is up to 46%. And it can be the first manifestation of HIV infection. It presents as bilaterally symmetric pruritic papules, and most of the time we'll find excoriations on the extremities. And in children, I have seen involvement of trunk, which is quite common. So we have to differentiate this condition from many other conditions like scabies, insect bite, and even eczema. Treatment is topical emollients, oral antihistamines, and steroids, topical steroids. A word about acute HIV exanthem and enanthem. And the frequency of this rash in acute HIV infection is 50%. The rash can be exanthematous, or it can be like pityriasis rosea over upper trunk and proximal limbs. Can involve palms and suits. Patients will have associated finding like fever, malaise, myalgias, arthritis, arthralgias, pharyngitis. And of course, we should see for enanthem in oral cavity, there will be erythema, there can be erosions. Patients can have dysphagia, retrosternal pain due to involvement of esophagus, which can even develop erosions and ulcers, and which can be a prominent complaint in few patients. So this was all about OIs, cutaneous OIs in context of PLHIV and CLHIV. Thank you very much.
Thank you so much, ma'am. Extremely sorry for the inconvenience. We'll share both the recordings. We'll merge and share both the recordings, ma'am.
Thank you.
Thank you, ma'am.
Challa. Okay.